First of all, I would like to thank Professor Riembo and Nilo for their continuous presence and support, and for the city being a partner of the IMAC since its very first beginning and for the last 4 years and this year as well. Well, today I'm going to share with you a 31 years old lady. She presented to us 3 days after her first cesarean section, 2015. The only positive past history was fall from height 20 years earlier, where she had a fracture, L5 fracture, and she was fixed using a graft from the right iliac crest. The patient presented with signs of hypovolemia, marked abdominal distension and right side abdominal pain, with massive bilateral lower limb edema. She was severely anemic. I want to tell you also that her blood pressure was 80/40 or maximum dose inotropes, and she had a venous duplex showing a bilateral iliofemoral DVT, and CT scan, which she had from outside our center, showed a massive right side retroperitoneal hematoma extending from the right iliac fossa to the right hypochondria. And clinically, there was severe ecchymotic patches along the back of the patient and the right side down to the right groin. So we started blood transfusion and fluid resuscitation, and then we transferred the patient to the cath lab, where we started by putting an IVC filter through right internal jugular approach, and then through a small right superficial femoral artery, mid-superficial femoral artery venous cut down, we did an angiogram. As we can see that there is apparently an aneurysm at the bifurcation of the common iliac artery, with free flow of blood and dye into the pelvis and retroperitoneal space. So we decided to insert a covered stent. It was a fluency 12 millimeter by 10 centimeter length. Then we did post-stenting balloon angioplasty. We used two size balloons so we can post-dilate the external iliac component and the common iliac component. And this is the completion angiogram. We had a good result. It was satisfactory for us. There is no free flow into the pelvis. However, we can see minimal leak or filling of this sac, but this result was satisfactory for us, and we decided to transfer the patient to the ICU. The patient actually stayed in the ICU for 2 weeks with serial ultrasound and duplex follow-up. She had complete resolution of the right-sided hematoma, and she was discharged. This is the 1 month follow-up after the procedure. The patient went home and she did this angiogram, and as we can see, there is a right iliac AV aneurysm. Maybe it's a communication between the internal iliac artery and vein, and also we had small aneurysms in the median sacral and one of the lumbar arteries. This is CT 6 months after the procedure. It showed no significant difference in the size of the aneurysm, and so we decided to follow the patient up. 2 months later, she came pregnant again with her second baby, and she decided to continue with her pregnancy. And so she was followed up for the upcoming 9 months using ultrasound and duplex. And this is the picture of the CT angio 1 year after delivery. This is 2 years from the past CT, which shows a huge or moderate enlargement of the right side ilio-arteriovenous aneurysm, with marked feeding vessels and collateral veins crossing from the right side to the left side. And this is her axial and sagittal cuts. So the patient started to develop right lower limb edema and symptoms of pelvic congestion, so we decided to get her again into the cath lab and do an angiogram to see what's happening. So we did a bilateral femoral access, and this is the picture on the left-hand side showing the beginning of tortuosity of the right external iliac artery, and there is multiple feeding vessels from the right common femoral branches and the profunda. And also on the left side, there are multiple branches coming from the left internal iliac artery. So we decided first to coil the left internal iliac artery On the left-hand side, we did coiling of the main left internal iliac artery, and actually while fixing one of the coils, it slipped into the right common iliac artery. However, this was snared carefully. And we did an angiogram on the right side. We can see the coils, but there is no occlusion of the complete thrombosis or occlusion of the left internal iliac artery, but we decided to follow her up. And also, we were deciding to do skeletonization of the right common femoral artery and trying to close all the feeding vessel on the right side, but the patient refused at this moment. Then she came back after 3 months with this CT. We can see that there is occlusion of the main left internal iliac artery with minimal reduction of the feeding vessel from the left side. However, we still have this aneurysm and multiple feeding vessels from the right side. From the axial and sagittal cuts, we thought that we have a type 1B endoleak beside type 2 endoleak. So the decision was to do a femoral cut down and then trying to straighten the right external iliac artery, extend the covered stent distally on the external iliac artery, and then have an angiogram and to see what we are going to do next. This is after we did femoral cut down on the right side. Actually, it was very difficult. We had extensive and severe fibrosis and adhesions between the femoral artery and the femoral vein. And during a dissection, we had one of the tributaries of the external iliac vein injured, and it really took us some time to control this bleeding. And this is the picture on the angiogram on the right side showing occlusion of the left internal iliac artery. However, there are multiple branches coming from the left side. We did an angiogram, a venogram from the venous side. We thought that actually we were prepared to put a venous stent in the vein if we had a path or a way through the right common iliac vein and the inferior vena cava. But this is the picture when we did a venogram, a huge venous dilatation crossing to the left side, and there is no common iliac vein or internal jugular vein. Actually, this took us quite some time, so we decided to abort, and we decided that we should conserve on this patient and then make a follow-up CT after 6 months to see what's going on. Well, the lesson that we learned that perforation of isolated iliac aneurysm are rare. However, they do occur, and they account for about 4% for ruptured aneurysm and 1% for non-ruptured aneurysm. It's very important to do a proper preoperative imaging, including multi-slice CT angiography. However, the complexity of these lesions sometimes don't give you the exact anatomical details, and we have to do a conventional angiography to know more about the feeding vessels and the type of endoleak. Of course, the predominant concern following any endovascular repair is the presence of persistent type 2 endoleak, and iliac AV aneurysm can be managed conservatively. However, long-term surveillance is recommended. Thank you.
Thank you very much.